Onassis Foundation. Dublab.
Welcome to the Quarantine Tapes, a daily podcast from Onassis LA and Dublab. Hosted by Paul Holdengräber, this series chronicles shifting paradigms in the era of social distancing.
Hello.
Hello, could I please speak with Dr. Jason Hill?
This is he.
Hello, Dr. Jason Hill. This is Paul Holdengräber calling you from the Quarantine Tapes. I'm so very, very happy that you could take the time to speak to us today. Thank you so much.
It is my pleasure, Paul.
I'd like you to describe for our listeners what you do, who you are, as it were, where you work.
Sure. So I live in New York City, and I am an emergency medicine physician, and I've been doing that for about 9 years, 4 as a resident and about 5 as an attending. I work in Manhattan at 2 different hospitals. I work at Columbia in Upper Manhattan, and then I work at a small community hospital called the Allen, which is right on the outskirts of the Bronx.
And could you describe what your days are like these days during this pandemic?
So right now, on this very day, the days are not too bad. I think we have all seen the benefit of the effects of social distancing. And so relative to the peak, it is night and day. You know, we're still seeing coronavirus cases, COVID cases. We're still seeing people very sick from it. But the sheer volume and the sheer madness of it is far, far different. And in fact, we're starting to slowly see more of what we had seen, what I call in peacetime, before the pandemic, creep back in much at the seams. And at the very moment, everything feels a bit like a waiting game as we see if a second wave hits or if the public health measures and our reopening strategies keep everything at bay.
It's such a privilege to talk to you, because what I'd like you to do as much as you possibly can and as much as feels comfortable, I'm sure part of it feels very uncomfortable, to take us into the ICU departments where you work. You wrote an article for BuzzFeed, which is quite extraordinary, called An ER Doctor Diary of 3 Brutal Weeks Fighting COVID-19, published on April 22nd, 2020. And in it you write, "I've never had more harrowing, more brutally honest, more meaningful, more exhausting conversations in my life." What were some of those conversations, perhaps some recent ones from the past week since you wrote that article?
Sure. So just a quick clarification. I don't work in the ICU. I work in the emergency department. Though in those days, in a lot of ways, they felt one and the same. But during that week, really there was a 3-week period, probably from beginning in mid to late March through mid to late April. It was unlike anything really any of us had ever seen or experienced. The emergency department it's always a busy place, especially where I work. Very poor neighborhood where a lot of people don't have primary care doctors and use the ER as their doctor's office. So it's always very busy. But what happened during the peak of coronavirus was not only the volume of patients we are seeing was much higher, it was the level of critical illness. And when it really ramped up, it was absolutely overwhelming. We were overwhelmed, we were overrun. So what would happen is, so
It's hard.
in normal times, on a typical shift in the ER, we may intubate one or two patients. You may have two or three very critically ill patients. During coronavirus, it was radically different. 1-2 patients an hour would come in incredibly sick, near death, very low oxygen levels, significant difficulty breathing. There were some shifts where 5, 6, 7 patients would die during a long, grueling 12-hour shift. On top of that, we would have 10 or 15 that were very much on the border of surviving, and they just kept coming. One thing that was shocking about this illness is the speed at which it could really affect people. So most of the time when someone is sick enough to need intubation, which is putting someone to sleep and putting a breathing tube down into their lungs and putting them on a life support machine, most of the time, those patients are chronically ill or unconscious or very confused. With coronavirus, those rules were changed over and over and over again. Patients that were healthy and fine 5, 6, 7 days ago, these were 20-year-olds, these were 30-year-olds, these were 60 and 70-year-olds, would come in and they would be on the verge of dying without getting intubated. But despite being short of breath and needing a lot of oxygen, they were alert and awake and able to have very frank conversations with you. And so we had those frank conversations over and over and over again. Those conversations really consisted of being frank about how sick they were, what would happen if we don't do the most aggressive measures, which are things like intubation and putting them on life support machines, but also letting them know that we couldn't tell them what their chances are of surviving, even if we do this. We could not tell them if they would not be dependent on life support forever. We just don't know enough about it. And so they would look to you for guidance. But these were, as you can imagine, very trying conversations. People open up to you in very profound ways during these times. You try to guide them using your clinical knowledge. You try to guide them using your humanity. At the end of the day, you respect their wishes. I think what made it even more trying is families were not allowed in the emergency department. And that is still the case. We could call them, we could FaceTime with them, but they could not be there, mostly to protect the family members. And so people were scared and they were alone. And you were really both their doctor and their advocate all at the same time.
You know, Dr. Hill, you tell a story of a 67-year-old Hispanic man, and you write, this man is not doing well. This man needs intubation to survive. He's 67 and only speaks Spanish. He's healthy. He's dying. And later on you say, if this disease attacked character instead of lungs, he would have a fighting chance. I found that extraordinary because these patients in extremis still maintain their strengths and character. I will certainly never forget this individual. Like many others, this was a otherwise fairly healthy man who was in his late 60s, who was in the ER probably for 25, 30 hours. The hospital was full. We were trying to create more beds, and so that was not uncommon. And I took care of him the last 12 or so hours of his life. He continued during that period to just do worse and worse. His breathing became increasingly more labored. His oxygen level became lower and lower. And multiple times we talked to him about what he wanted to do, how he wanted to live the rest of his life.
and there are really two options. One is we put you to sleep, we intubate you, and we try to see you through this using the most advanced care we have in medicine. And the other is we make you comfortable and let you die on your own terms. That includes things like pushes of morphine, which make people not feel like they're short of breath, make people very comfortable, and let them die in peace. He was very aware of what was going on, and he was very strong, and he was very stoic, and he was very clear of his desires. He wanted no chance to ever be on a life support machine, and he would even remark that his wife would never be able to take him off of that, even if it was the right thing. And so he made the decision, both for himself as well as to spare his family.
What did he say to you?
He said mostly that. He said that I never want to be on a machine. I don't want to be on the machine. And that if he was not going to get off the machine, he knew, even if his family knew that it was not in line with his wishes, they would not have the strength to take him off of it, to pull the plug. And so he was just very clear. And we said in no uncertain terms, we just want you to be clear about this. This is it. This is the end.
Did you say to him, "Se está muriendo, señor, es el fin"?
Yeah, I speak some Spanish, certainly. But for these conversations, we have fluent Spanish interpreters. So I wanted to make sure there was absolutely no language barrier. Yeah, exactly. But those are the words I recall them saying when I said, "This is the end. You are dying." And they took his hand and looked him in the eye and they said, "Señor, es el fin. Se está muriendo. Es el fin." And he welled up he had tears in his eyes, and he understood. It's still shocking, but he understood, and he nodded his head, and he held our hands, and he said, "Thank you."
And then you write, he wanted to say goodbye to his family, and you arranged for a video call with his family, and you say, he says goodbye. They say they love him in a dozen different ways. He touches the screen, a digital handhold in a pandemic age. You must be living through such moments, perhaps again and again.
One of the hardest things about this truly is having patients alone. No family is allowed for public health reasons, for the protection of the family. And so the one option we have to get around this we have a number of iPads, and we can FaceTime families. And we've done this so many times near the end of life, we will do this. And as you can imagine, these patients are quite ill. So certainly they can't often hold the iPad themselves. So you call the family and they see your face, a stranger's face, with a mask on and a face shield on and a cap on. And you explain to them what's going on. And then you put the screen in front of the patient and you hold it there and you let the patient say goodbye and the family says goodbye, and you bear witness to these conversations that are equal parts touching and heartbreaking and soul destroying and powerful and beautiful and tragic all at the same time. You have very mixed feelings about being a bit of a voyeur, but it is a important role and it is the only way it can be done. You also painfully cannot let it go on forever because you have many other patients to attend to.
You talk about that so well in that article, just how little time there is really. I mean, you don't say this, but I'll say it. But there's so little time to be human because you're running around. Everything is beeping. There is no moment of respite. You talk about a new form of exhaustion. I mean, I know doctors work crazy hours, but it sounds like a week or 2 or 3 ago, it was just beyond anything you even trained for.
Yeah. What would happen when the ER was just, again, truly, truly overrun? You had so many critically ill patients. All our rooms were full. We were lining patients in hallways, angling the stretchers like airport parking just to fit some in. And the most effective medicine that we had was oxygen. But we have a limited supply of spigots on the wall that lead to our central oxygen. And so patients who were in the hallways were relying on an oxygen tank, and a lot of them needed such high levels of oxygen that those tanks would run out very quickly. And so we invented a new term, which we called oxygen rounds, which was once an hour, sometimes more, you would just need to take a lap around the ER and physically look at everybody and look at their oxygen level and check their oxygen tank. And invariably, sometime between the hour before and that hour, someone was not doing well. Someone had gotten a little confused and taken off their mask. Someone would be gasping for air. Someone would be blue. Every once in a while, someone would just be dead every once in a while. And it gave you an endless sense of paranoia. And when you would have to, say, intubate somebody or run a cardiac arrest or deal with a very critically ill patient that required a lot of time and a lot of attention, you realized in the back of your mind that while you were doing this, there was a very real possibility that somebody else was decompensating. It certainly was not out of negligence. It's not out of anybody's negligence. It was just so many people and so many things going on, and only so many bodies on the ground.
And you describe ventilators and other machines as the background music of a pandemic. Can you elaborate a little bit on that?
Yeah, it's. I still recall you would walk into the ER during the peak, and the streets of New York they're quiet. They were incredibly quiet, silent. No one was out. Buildings or stores were closed. Sidewalks were bare. No street vendors. It was almost peaceful. And then the moment you walk into the ER, it was a cacophony of alerts and alarms. I think on probably the busiest single shift that I worked, I had 15 patients who were intubated at the start of my shift, plus probably another 20 or 30 that were critically ill on what are called non-rebreathers, the largest amount of oxygen we can give somebody. And all of these patients are on monitors. And all those monitors, every single one was beeping alarms that heart rates were too fast, or oxygen levels were too low, or breathing rates were too fast. Even the patients that are intubated, and this is probably 40 or so different monitors, different ventilators, and that was just the sound of the ER. That was it. All around you, 360 degrees, all day, all night. And you essentially got used to it. You somewhat ignored it. It only told you what you already knew, which was everyone was critically ill, and you had to continuously check on everybody. And many times when people are critically ill, the best way to check on them is to look at their blood test results. In the case of coronavirus, the best way to check on people was to stand at their bedside and see how their breathing was and see how their oxygen was. So it was a very, very, what we call clinical pandemic. It was a very bedside pandemic. You needed to walk around. You needed to physically look and check on every single patient.
And then you describe this moment where 4 or 5 of your colleagues people who you've worked with, doctors with whom you've worked on saving lives and on losing lives, come in themselves, and the different relationship you have to them than to patients with whom you feel tremendous empathy but don't know them, much like that 67-year-old man you were describing before, who spent 2 days in the hospital. You didn't know him, though you have a connection with him that probably will never disappear. That must have been so difficult.
Yeah. As an emergency doctor, you see a lot of death and dying your entire career. And you talk to lots of families about the fact that one of their loved ones has died, and you break a lot of bad news, and you do that with empathy, and you do that with humanism, but you also protect yourself, and you do that by having a somewhat of a detached distance.
Yeah.
There's a reason that doctors classically are not supposed to care for their family members, because all those barriers fall away. And hands down, one of the hardest things about this pandemic for us is having friends and colleagues get ill and having to care for them. And that is different. These are your friends. These are your colleagues. These are people that you have known for years. And when they look at you, it feels different, and they're scared. And you know why they're scared, and they know why they're scared.
They know it better. They know it better than many of the patients you have who you don't know. That must be so hard, because you can't tell them you're dying. They might know it. They might know what the signs are.
Yeah, and so many times they would try to reassure me, which was backwards and both, again, touching and heartbreaking.
What did they say to you? What did they say to you to try to reassure you?
Sometimes it was just a look in the eye, or sometimes they would just, they would know that I was checking on them maybe far more than I needed to. Sometimes I remember I reached out to hold her hand, and she said, you're not allowed to do that. You can't do that. And I'm going to be okay. It's okay. I'm going to get through this. It's tears would well up tears, and it was such a deep respect as well as such incomprehensible fear. The moment I would go to the cafeteria and just get a nice salad, better than the sandwiches that we have in the ER, and bring it to them, the smallest thing that I could do to help a little bit, just to reassure a little bit. And there was almost a parade of nurses and techs and doctors just coming by, just to check on, just to let them know that we were here and we were going to do everything we could, and we loved them. And, we lost some. Certainly we lost colleagues and we lost friends, and that still hangs heavy in the air.
The piece I've been referring to, Dr. Hill, was written 5 weeks ago, or was printed 5 weeks ago, maybe written 6 weeks ago. If you were to project what might happen in 6 weeks, do you have a sense? You said earlier that things are better, but you also said there might be a second wave. And I'm wondering, of course, I'm always reminded of Mark Twain's great line that one can't really make predictions about the future. It's very hard, but I'm wondering if you had to imagine what 6 weeks from now will look like.
I think truly none of us know. And I think what we do right now is critical. And what we do over the next few weeks is critical. I think in a lot of ways, we're fighting a thing that has all the biological advantages. The odds are in some ways maybe stacked against us. And what we've done in terms of social distancing and public health has put the brakes on this. It has, at least in the short term, saved us We went from overwhelmed and overrun and having the most difficult, harrowing experiences for weeks that I can never imagine to feeling under control. A lot of that is operationally. We have created more space in the hospital, and most of that is we have slowed the spread of this virus to a very high degree because of our effects of social distancing. And so as we move to reopen, it could go either way. There is without a doubt the possibility that we could spark another large outbreak. And that could be in New York, that could be anywhere in the country. And if that happens, we will go right back to where we were. The hope is that as we move forward, we do it intelligently and we listen to the guidance of public health, and we encourage people to continue wearing their masks and to stay 6 feet away and social distance as we open up and as we see what happens. And as more cases come to be, if there is an uptake, then we have to be willing to take a step back. And I think that's the only way we're going to move forward safely. It feels, again, like a calm before a storm. And I think all of us assume there will be some sort of increase in cases as we open society. But our hope is that it won't return to the overwhelming degree. Nobody should have to live through that. Not doctors, not nurses, not techs, not patients.
You know, in closing, like everyone else, or like many people, I clap at 8 o'clock in Los Angeles. But I'm wondering, beyond clapping, which is, you know, symbolic, how can that clapping turn into action? What kind of changes would you like to see in the healthcare system for the workers, and different ways in which we might be able to move forward after this pandemic subsides?
I think one thing that this pandemic has laid bare is the inequities in our healthcare system and the undue burden on the poor and on people of color. The disproportionate impact that it has had on poor communities is telling, is shocking. You know, I work in a very poor community, and so when patients were infected but well enough to be discharged, they would be discharged back to their families, and they were terrified. They, over and over again, would worry their greatest worry. You know, they would live in a multi-generational home with 6 other family members that they couldn't really socially distance from. They were worried that they would infect their elderly parents. They were worried they would infect their children, and they did not know what to do. And there was no solution that we could give them. The current state of the world with our current healthcare system is that if you're poor, you have less chance of having insurance. It's harder to exercise and eat healthy, and so you have more underlying disease. And then again, your social structure is such that you are just at increased risk from any infectious illness. And so I think moves to address that are paramount for moving forward. You know, it breaks my heart that the community that I serve is just going to get hit harder by this virus because of the extra burdens that poverty places. And so I think increased access to care, easier health insurance, more affordable health care, more universal access is going to be paramount to helping not only these communities, but really the country at large be stronger, be healthier.
Dr. Hill, I can't thank you enough. Thank you so much for taking your time, and all the best. Stay safe. It's been a pleasure to talk to you. Thank you so much.
It's been my absolute pleasure, Paul. Thank you.
Bye-bye.
To support this show and Dublab's progressive programming, go to dublab.com/support.